Ian, do you know whether Councillor Huffman is going to be joining us?
I do not. I was assuming that both would be in attendance. We hadn't spoken on the subject, whether they were attending or not.
I've got Councillor Taylor up on the participants.
Okay.
But I don't see Councillor Huffman and I don't see Councillor Patterson, who I talked to last night. He's supposed to be joining as well. It's now 1 o'clock.
Hello, Marlene. Well, we could always have a staff member give them a courtesy call to see if they would like to attend, and maybe it's a technical issue.
Could be.
Councillor Taylor, Councillor Huffman are not. Okay. I see an RT in the bottom there. That's not him.
Oh, I'm here. I've got my camera.
Oh, there you are. I can hear you.
Is my picture?
On.
Councillor Taylor, you're not going to run down to Gilbertson, are you?
No, I don't think so. Am I up?
It was T. That's T.
There he is.
Fingers crossed.
All right, so who are we missing then? I think just Councillor Huffman. Councillor Patterson?
Councillor Patterson told me last night that he would be joining us, so I'm a bit surprised that he's not on yet.
Is Owen still on? I can't get him.
We have 5, so just seeing Councillor Huffman, we can get started then. Hopefully she'll join us.
He should be in there now.
Are you gonna let us see?
Hi everyone. Councillor Patterson did just join the room.
Councillor Patterson joined, okay. Okay. Hi, Marlene.
Hi, Councillor Del Monte.
Okay, I'm ready to start the meeting. So welcome everybody under these unusual circumstances, but it is what it is. So I know everybody wants to get out there and do other things and enjoy the sunshine. So let's get the meeting started. The only thing I want to clarify, Marlene, is that when I call the vote, I'm going to be verbally. I'll go through each counselor and ask them to say yes or no, whether they're in favor of the motion. So we'll start with disclosures of interest. Do I have any? Anybody got a disclosure? Okay. Any agenda? Anyone? Okay. Item 3, adoption of the advisory committee meeting minutes from January the 16th, 2020. Motion to receive.
Ian, I will move.
Moved by Councillor Rabbit, seconder. Seconder for that motion.
I will second.
Okay, Councillor Taylor, thank you. And so we'll call the Councillor Patterson, did he join?
Yep, he's here.
He's here. Councillor Patterson? Yes or no?
Yes, in favor, Chair Thomas.
Okay.
Your mic is very muffled.
Wow, okay. Councillor Corbett? Councillor Corbett?
He's there.
Councillor Corbett, are you in favor of the motion?
He's frozen.
I think we froze.
Yeah, he's frozen.
Okay, there's a problem there with Councillor Corbett. I'm going to go on to Councillor Taylor. Are you in favor of the motion?
Yes.
Councillor Rabbit?
Yes.
Councillor Hoffman?
I don't think she's on.
He's not? Councillor Hoffman?
Huffman is on. We we don't see her name on the screen, and I don't believe we've heard from her either. So I would say that she's currently not on.
Okay, then I'm in favor of the motion, so the motion is carried 5-0. So we'll move on to update from those reports. And Marlene, is there anything from those minutes or anything you want to add under General Manager's report?
Can I ask if everybody could put their video on mute unless you're talking? We're just getting feedback and it's hard to hear. So typically if we all are on mute, unless you're speaking, it tends to work a little bit better. So if you could kindly do that would be great.
Okay.
So, with the exception maybe of the chair who has to keep it, the dialogue going. So, so the reports, it's been a long time, so welcome back everybody. We haven't had an advisory committee for quite some time. We weren't enabled to until June as per council direction, so this is our first meeting. Really quite a catch-up meeting from our pre-planned agenda back from March. So welcome back everybody. It's great to see everybody back, and although it's in a different format, we'll get through this slowly and hopefully get through the agenda today. So all reports were carried from before. Just regarding a general manager update, I'm actually going to give a bit of a public health update, if I may. Dr. Nasathuri isn't able to join us today. He will be at our board meeting tomorrow afternoon at 3 o'clock. What's going on with the board, with public health. As you are aware, we continue to have an outbreak at Anson Place. We are quite optimistic that we'll be able to clear that soon. We have a few other homes that we have an outbreak assessment, and I think one in outbreak, and that's really related to staff having come back positive due to surveillance testing. We are currently testing all the staff twice a month now as per a provincial direction, so we'll continue to do that. We are working with our Ontario Health partners on congregate settings in the long-term care, and pleased to say that all of our homes in Oldham and Norfolk are what we're calling in the green, which is a good thing. They're all managing well and stable at this point in time. We are looking with the long-term care congregate settings. We are looking at doing opening up for visits. So there's a lot of work going on for our homes to be able to open up to family visits. Additionally, with that, it doesn't just include our long-term care, it also includes our retirement homes. So a lot of work going on with managing the congregate settings.
Marty, lost your
Muted your mic there.
You muted your mic?
Can you hear me?
Yes, I can now.
Okay, so we have about 100 of those cases were from Anson Place, and as you know, we have an outbreak in a farm, and that's almost 200 of our cases there. Related to the current outbreak at the migrant farm, we have about 170 plus positive workers. We have about another 20 that are associated with that outbreak. So we're getting close to 200. Over the last couple of days, unfortunately, we have had another bunkhouse at the same farm that had been potentially exposed initially and are starting to become ill, and a couple of them have tested positive, and we have had to transfer 2 of them to hospital, and unfortunately one of those migrant farm workers is currently in the ICU. So we continue to do the outbreak management for the farm enterprise. We have several other farms that have some workers that are unwell, and we're in outbreak assessment with them. So we've started to do some testing, and we're waiting for those results to come back in as well. We are working on exploring testing with all of the migrant farm workers, and I actually had a meeting with the Ag Committee with our CAO last night. So we're creating a plan to work on that as well. So you'll hear more from Dr. Nasathuri tomorrow. I'll just leave it at that for now. There's lots going on with everybody starting to open up. As you know, we're going into stage 2 from the province tomorrow at midnight. So we're working on opening up, opening up a lot of those businesses as well, and all of the other things associated with that. So I'll stop there because I could probably talk for the rest of the meeting, but I'm happy to answer any questions, or the team here is happy to answer any questions that the committee may have.
Hey, thanks, Marlene. Are there any questions from members of the committee? Okay, I see no hands. And so Marlene, no update as Dr. Nasathuri is not with us. No update for Medical Officer of Health. So we'll move on to staff reports. With the first one being on page 9, HSS 2007, in regards to the vector-borne disease program update. Who's going to speak to this report?
So I'm going to turn it over to Costa, the public health inspector, to present our first report, and then the team will be able to answer any questions from committee.
Okay, hi everybody. My name is Costa Lysenko. I'm the vector-borne lead and the health inspector with the health unit. I'm also on the vector-borne disease working group. I do the tick dragging in the community, and I'm also the primary contact of healthcare workers or the public if you're seeking advice on Lyme disease. So you guys can hear me okay?
Yeah.
Yeah. Okay, so in this report, we'll just discuss the health unit's a vector-borne disease program that's in place to monitor local tick and mosquito populations for diseases such as Lyme disease, West Nile virus, Eastern equine encephalitis, and other emerging public health diseases. And then the report will highlight the vector-borne disease activities from the previous year that we undertook, and also the overview of the plans for this year, for 2020. And in order to prioritize and plan activities for the vector-borne disease program, the health unit traps and tests mosquitoes and ticks in the county. We review official reports and statistics from other public health agencies. And we also do interviews for. Sorry, we also interview interviews and questionnaires for those individuals who have been personally affected by reportable diseases. So the first major vector-borne disease that I'll talk about is Lyme disease, and it's an important component of our vector-borne disease program.
Bernie Corbett is now joining.
Just a bit of a background, Lyme disease is caused by a bacteria called, by the Borrelia bacterium, and it's transmitted to humans by the bites of infected deer ticks. So in 2019, the health unit did not identify any new risk areas for Lyme disease, and the majority of the health unit of the Haldeman and Norfolk counties have been established as a risk area for Lyme disease. In 2019, I did the tick dragging in the spring and the fall for the areas we identified. We found ticks in the spring on all of the locations, but when we went back in the fall, we weren't able to find ticks there, so we couldn't establish the life cycle of ticks in those areas. In terms of Lyme disease cases, in 2019, there was 1,025 cases in Ontario, and then 11 cases in Haldeman, Norfolk, compared to 3 cases the previous year. And for the county, for the province, the number of cases almost doubled since 2018, when there was 612 cases. In terms of the public health awareness activities, in 2019, the health unit started a promotional campaign focused on schools. The aim was to raise awareness and build supportive environments to prevent, mitigate, and respond to children and school staff being exposed to tick bites. And then we provided them with educational resources with varying levels of information depending on the grade in which the kids were in. And also we did a presentation to those school boards to provide some additional information. In addition to that, a number of public health education activities were performed for Lyme disease from May to December 2019. And this was through radio, social media, newspapers, our website, and also smart TV ads around Haldeman, Norfolk. And for 2020, most of the Norfolk County has been identified as a risk area, and we're not going to be doing tick dragging this year due to the COVID outbreak. Originally, it was planned to do tick dragging, focusing on sites found within Haldeman County, which was the only area that hasn't been yet identified as a risk area. And then we'll continue to develop promotional campaigns to raise awareness and build supportive environments to prevent and mitigate tick exposures via social network messaging and other media methods. We're also working to replace warned tick signage around the county, specifically around the provincial parks. And also we're planning to extend the promotional materials provided to the Grand Erie District School Board to extend that to other school boards, including the Catholic School Board. Finally, we will distribute more tick kits containing tick removal tools and tick identification information to local provincial parks that can then distribute them to their patrons. So that's Lyme disease, which was the major component. And then I'll talk about West Nile virus next. Just the background. So West Nile virus fever is an infection caused by West Nile virus by the West Nile virus, typically spread by mosquitoes that become infected after feeding on birds carrying the virus. And in 80% of the infections, people have fewer or no symptoms. 20% of the people develop fever, headache, vomiting, or a rash. And then in less than 1% of the population, there's inflammation of the brain or the spinal cord. So in terms of what we did in 2019, there was 8 mosquito trap locations that were set out, 4 in Norfolk County and 4 in Haldeman County, that were set up bi-weekly between June and September. After the mosquitoes were analyzed, after collection, there was no positive West Nile virus mosquito pools identified in Haldeman and Norfolk counties. The West Nile virus activity in the Haldeman, Norfolk, as well as most of the province, was lower than the previous year, and this is generally attributed just to a cooler summer. And in terms of human cases, there was 1 human case of West Nile virus identified in 2019 compared to 6 human cases in the previous year. And in 2019, there was 21 cases in all of Ontario for West Nile virus. In terms of public awareness activities, the health unit did. These were put on between May and December 2019, and including information that was spread through radio, print, smart TV ads, as well as communications via social media and our webpage. And then the plans for 2020 will continue to trap mosquitoes around 8 sites in Haldeman, Norfolk, perform laboratory analysis on them to determine whether there's any pools that are positive for West Nile virus, as well as Eastern equine encephalitis virus, which I'll talk about next. And then this year, the Haldeman Norfolk program will focus mostly on surveillance, case management, promotion, and responding to standing water issues. So the next, I'll talk about Eastern equine encephalitis, also known as Legion sickness. So that's spread to humans and horses by mosquitoes and can result in neurological issues. So just like West Nile virus, we have no mosquitoes that were found to be positive for Eastern equine encephalitis. And then no human cases were identified in Haldeman, Norfolk in 2019. And provincially, there was a total of 7 cases of Eastern equine encephalitis, which was low in the previous year. So just like West Nile virus, we did a bunch of public awareness activities through radio, social media, newspapers, our website, and smart TV ads. And in 2020, we'll continue with the sort of public awareness activities as well as the mosquito trapping that I discussed previously. And lastly, I'll just talk about emerging diseases. So there are a number of emerging mosquito-borne diseases that the health unit continues to monitor. Some of the most important vector-borne diseases include Zika virus, dengue fever, and chikungunya. And in addition to that, across Canada, there's been a rise in tick-related infections beyond Lyme disease. Other tick-borne diseases that can impact human health include anaplasmosis, babiosis, and Powassan virus. So we'll continue to monitor for any new cases of these diseases. And the messaging around the use of personal protective equipment, landscaping precautions, and awareness remain the main methods to help protect the public as the diseases are spread by ticks and mosquitoes. So that's all I have for the vector-borne.
Okay, thank you, Katya. Are there any questions to staff on the report?
It's Bernie here, and I just would like to make a comment, and I thank you. I just got into hearing the discussion. This process is a very extremely frustrating process for me, as I want to participate. Going through Zoom, it didn't work well last night, and this morning I was on earlier and got through this process. What they found for me, it was better for me to go to the library in Dunnville. So in the future, if you could make those arrangements, I'd be quite happy to do so. I want to participate. I did have an addition to the agenda, and it's a comment on COVID-19 response. I did agree with the minutes. So other than that, I'll participate in the next couple of discussions, and thank you. It is frustrating, very frustrating.
If I may, feedback and Councillor Corbett, we'll continue to work with Parks on making this process smoother as we move forward. So we'll be patient collectively, and we'll get through this. If you aren't able to speak or see us, if you even want to send me an email, I'll keep it, and we'll make sure that we're able to participate fully this afternoon.
Yeah, the library, I didn't have difficulties at all. I know when they checked me before, when we had the previous meetings, that it was said that probably my reception for getting on was weak, and I've experienced it. Last night I had difficulty too, and I have ones with the Conservation Authority that give problems. So it's not an acceptable process for me. It may be for others, but not for me.
It's working on my laptop, but I don't know if they know I'm here. I mean,
yeah,
I must.
Okay, are there other questions to staff on this report?
Yes, I see.
Councillor Taylor.
Councillor Taylor?
Yeah, Councillor Del Monte, through you, I have a couple questions. Do you mind if I just rattle them all off after I get an answer and then go to the next one?
Go ahead.
Perfect. Thank you, and through you, what portion of Ontario is considered the hot zone? Is it basically southern Ontario?
Yeah, to answer your question, yeah, most of the hot zones are around Haldimand, Norfolk, and Long Point. There's another hot point around, what's the area called? Around Kingston at Sandbanks Provincial Parks. And there's another one that's closer to Sudbury, Northwest Ontario as well.
Okay, because when it says cases doubled since 2018 to 2019 in Ontario, or roughly doubled, that's right. Basically just looking at the hot zones, right? Because the other areas don't really have much in terms of Lyme disease.
That would account for the whole province, I believe. It's just the numbers get pulled from when somebody gets tested for Lyme disease and they're confirmed to be positive. I would imagine that they would mostly come from those areas, but I wouldn't be able to confirm because it's just the data from the province.
Okay, thank you. And then finally, with the emerging diseases, talking about tick-borne diseases, are the three infections listed here, are they also spread by deer ticks, or is that other types of ticks that are carrying those?
Are you referring to anaplasmosis, babiosis, and palosan?
Yeah.
Yeah. I believe those ones are spread by other ticks other than deer ticks as well.
All right, thank you. Those are my questions. Thank you.
Any other questions from committee? Okay,
Councillor Rabbits here. I have a few questions.
Councillor Rabbits, go ahead.
Thank you, and through you, Chair Del Monte. My questions are a little bit more general in nature with regards to how to report a stagnant pool of water, or how to request, maybe someone from the health unit to come and see an area, because with the reduced maintenance specifically we have in Norfolk County, grasses are taller, and I've had some reports, about our public spaces that we're maintaining having taller grasses in some areas, next to stormwater retention ponds, whether they be parks or cemeteries. And my question is, has our health unit sort of noticed any either complaints or reports about those areas? We do really have a lot of high water right now that we're continuing to struggle with, and there's inland flooding. And I was just wondering, how a resident could, maybe report some of those areas that aren't having boots on the ground like we would normally be, keeping a higher standard of maintenance in those areas. And, I've got a bunch of cards that are since out of date. If I could, I see Marlene feverishly taking notes. I appreciate that, Marlene. But I'm going to show you a couple of cards that I have here, just to show you, even from a counselor's perspective, it can get confusing who you call or how you report something. I don't know if you recall this green card. It's going to be backwards on my screen. So it's from 2018. It's got a 1877 number to report all public health emergencies. I imagine that's an old one. There's another one I've got. Thanks for bearing with me, everyone. That's a whiter one. That's from 2019. All right, and it's got, all of your FPCA on the back, and it's got, and it does have the same 1877 number, and it says, reportable diseases, any sort of public health emergency / hazards. So I want to know if I'm still to be giving out that number specifically, or if there is a public health inspector that we'd rather, sort of direct those questions to. I've actually had it come up just recently, so I think that's my first question.
So if I may,
sorry,
I think I heard you just asking about the cards, so you just cut out a little bit here and there. So related to those cards, Councillor Rabbits, through the chair, the green card is actually an on-call emergency response card, so it's probably outdated and we can reissue it. The white card was a request, I believe, from this advisory committee on contact information. So that one we can check to make sure it's still current. I understand it is, but we'll double check. Even if you want to bring it tomorrow, I'll make sure I have a copy of it at the Board of Health, and we can just recirculate it and ensure that it's accurate. The 1-800 numbers are after-hour number, I believe, and that's the number to call. During the day, if people have concerns, they can always call the front desk, and it'll be triaged to the appropriate person. Although we're not open to the public, we have our customer service staff still here, and staff are able to respond to those calls.
Thank you for that. And I guess as a follow-up, I think that'd be great if you could just affirm that and maybe recirculate that to all board members, that information. And I was curious about, I sort of alluded to it earlier about the concern with maintenance and water. And I was just wondering if anything's been reported, or from the presenter of this report, how we're working with our public works, our community services divisions at maintain some of these areas. and if there's been any complaints, or if we have any countermeasures, or we're concerned about this taller grass and these pooling areas of water that are, I would say, unusual for this time of year in the places that they're in.
Hi, Councillor. I can try to answer at least part of that, just Costa Health Inspector here. So far, at least this year, I believe we just received one complaint about standing water. And generally, if the public does have a concern about it, they can call the General Health Unit number, as Marlene was alluding to, and it would be directed to the environmental health team, and the health inspector would follow up on a case-by-case basis. So we haven't had too many complaints, one that I'm just aware of. I can't personally speak to the maintenance side of it personally. I don't know.
I can add a little bit, if I may, through the chair. I'm not aware of any complaints outside of what Costas just shared with us from the corporation as a whole, but I can definitely take it back to my SLT colleagues and see if we've had complaints and what actions have been taken or are planned to take in that event. At this point, I don't have any of that information. I haven't heard. We had SLT yesterday that I know Ms. Van Dyke was there for me yesterday. I don't believe there's been anything that's brought forward to have a bigger conversation, but I can definitely take that back. I've got it documented.
Okay, are there any other questions on this report? Then I'll ask for mover and seconder for page 16.
Seconded.
Okay, seconded by Councilor Taylor. Okay, so I will call for the vote. Councilor Corbett?
In favor.
Councilor Patterson?
Yes, in favor.
Councilor Rabbit?
Yes, in favor.
And Councilor Taylor?
Yes.
And I'm in favor, so that motion's carried 5-0. Next report on the agenda is on page 19, and it's HSS 2008. It's in regards to the Children's Oral Health Information Report.
I think we are on. Through the chair, I believe Mr. Shaw is presenting the report, and I believe he's in his office, and he'll be providing the update from his office. Thank you, Christine. You should be running a block.
I don't know if he's coming in, but Danielle and PK are coming in.
Oh, I take that back. They've chosen to join us in the room, so we're just gonna clean so we can have the next participant in the meeting. You know what? You're presenting. You're just clean here so Saya can present. Yeah. Oh. You're presenting? Yeah. No, I'll stand back here. Just introduce yourself. Okay. Thank you, Crystal. Thank you. All right. Good afternoon, committee members. Good afternoon, everybody. My name is Kiki Ogusulire, and I'm the Program Manager for School Health and Substance Use. I hope you can all hear me. So today I'll be giving an overview of the Oral Health Report HSS 2008 for the 2018-2019 school year, which will be presented to the Board of Health. So the objective of the oral health program is to improve the oral health of children by screening eligible children and providing access to preventive and providing access to preventive care, as well as provide referral services to children and youth from low-income families. We have two components of the oral health program: the oral health screening, as well as the Healthy Smiles Ontario program. So the oral health screening is conducted in schools and communities and community clinics, by our health unit staff. We identify children with urgent and non-urgent dental needs
and our staff facilitate referrals so that children can receive the care that they need. In 2018-2019 school year, children were screened in all the 38 publicly funded elementary schools, as well as 2 private schools. Oral screening was offered to all children in junior kindergarten, senior kindergarten, and grade 2, as well as some children in grades 4 and 7 in schools that were identified as having higher screening intensity. So for the year 2018-2019, we screened a total of 3,352 children. Of that number, 10%, which is 335 children, were identified as having urgent needs, and 241 children were identified as having non-urgent needs. For the Healthy Smiles Ontario program, it's a basic dental program funded by the Ontario government and provides preventive and restorative services for children and youth 17 years and below of low-income families. The children are enrolled in the HSO program based on financial eligibility, as well as through identification during the oral screening process. Students identified as requiring urgent dental treatment qualify for the Essential Emergency Services Stream, which we call the EASE, and this is delivered by participating community dental clinics. Students identified as having non-urgent tooth decay are able to access care through our Healthy Smiles Ontario clinics here in our offices, Simcoe, Dunnville, and Langton. Our dental staff also attend the Help Center night 1 evening a month to provide oral health screening, topical varnish applications, and they facilitate enrollment of children into the HSO program within the Mennonite population. For the Healthy Smiles Ontario program in 2018-2019, we saw a total number of 1,020 children. Of that number, 465 children were new enrollments, 421 children were identified as having urgent needs, and 421 children had some form of treatment offered within our clinics. The health unit also offers targeted intervention programs to schools that screen at a high intensity level. 1 or 2 schools per year offer these programs. We would like to offer more schools, but due to limited resources, we're able to only offer 1 or 2 schools per year at the moment. One of such programs is the toothbrushing initiatives, where the students get to brush their teeth as part of their daily school routine. Another of such programs is the fluoride program, where students receive fluoride varnish applications in school once or twice a year. So for that school year, 359 students were enrolled in the toothbrushing initiative, and 530 students were seen through the fluoride varnish program. So in conclusion, we can say that there has been an appreciable improvement in the oral health of children and youth in the Haldimand and Norfolk counties. Statistically, we have seen a decline in the percentage of children having urgent and non-urgent cases. In 2014-2015, we had 32% of children who had urgent and non-urgent needs. However, in this 2018-2019, that percentage has reduced to 17%. The health unit's oral health program continues to work towards program outcomes to improve the oral health of youth and children and help improve access to care for children from low-income families. Thank you. Myself and Danielle Smale, our clinical lead for the dental program, will be here to answer any questions that you may have.
Thank you, Kiki. Are there any questions to staff on this report?
I have two, please.
Go ahead, Bernie.
The first one is with regard to the statistics. I would note from reading that statistics, the program is working well, if you can comment on that. And the second one would be, there seems to be an above average results for the Mennonite community. Is there anything distinctive about that? Thank you.
With the Mennonite community, just culturally, they don't do oral hygiene at home and maintain their teeth. So we do extra screenings for them. We do the brushing program and the fluoride program in their school, and it seems to be working well. That's why we're doing the brushing program, is at home they don't brush. So it has given really good results. That's kind of what we've seen there, is we've targeted that population, and what we're doing seems to be working.
And the program statistics, as I say, it looks like the program was working well. Just a general comment about that, please.
For all the kids screened, that the stats are going down? Yes. A lot of it is that we have targeted the Mennonite population, and that population was, you know, our highest stats, and it is working for them, and thus it seems to be working for the whole population. I think a lot of it is we've also tightened up on our school screening and our follow-up. So we're following up kids, making sure that they get treatment, which means that their family knows about the program. So years down the road, they're getting access before we even find them at school. We're also seeing an increase in our preventive clinics. So people have a dental home, so we're not finding them at school. We're doing preventive things, we're seeing them regularly, and thus hopefully with them having a dental home preventatively, we're not getting as much school findings, I think, is another reason for that as well.
I think it's working well, preventive rather than actually putting out the money in the end. So I'm very thankful we have the program.
Yeah. No, I agree.
Any other questions on the report?
I have a couple there, Tony, if that's okay.
Hey, go ahead, Councilor.
Thank you, and through you. So what differences are we expecting in the program with this COVID-19 world?
Renovations. We're waiting also for the seniors dental clinic, and that may allow us some things built in with that. But I think we have to wait for Public Health Ontario to tell us what's required, and then we have to decide as a health unit what services we offer, and that will determine if there's a big budget change or not.
Thank you so much.
Any other questions? Receive the report as information. Can I have a mover and seconder?
So moved.
Councillor Taylor's moved. Seconder?
Patterson will second.
Thanks, Councillor Patterson. So I'll call the vote. Councillor Corbett?
In favor.
Councillor Patterson?
Yes, in favor.
Councillor Rabbit?
Yes, I'm in favor.
Councillor Taylor?
Yes.
I'm in favor as well, so the motion is carried 5-0. We'll move on to social services and housing, with the first report being on page 25. It's in regards to the update on the 10-year homelessness and housing plan.
So good afternoon, everyone. It's Heidi. Can everyone hear me okay?
Yes, I can hear.
Okay, perfect. So the first report is to provide committee with the draft updated 10-year housing and homelessness plan. Committee will remember that we had previously brought the terms of reference for the 5-year review of our 10-year housing and homelessness plan. According to the Housing Services Act, it is mandated that we have a plan to address housing and homelessness issues in our community. And after the first 5 years of the plan, we are required to do a full review and update of our community needs analysis. But I want to be really clear that we did not just do this because we were mandated to do it. The 10-year housing and homelessness plan is a very important document for our department and for our community, because it really provides us with the data that we need around what we know are our needs in terms of affordable housing and homeless prevention services. And it is a living document. We, in reviewing the plan, we had a technical committee of community stakeholders, and you will see in the report that part of the implementation includes an implementation committee that again includes members of our community who are our key partners in addressing housing and homelessness issues. It's really important to us that this is not a social services and housing department plan, that this is a community plan that we work with the community to move forward. So on page 2 of the report, you can see that 4 main housing gaps were identified. A need for affordable rental housing options for households with low incomes, a need for a broader range of dwelling types, tenures, and uses, a need for additional supportive housing units, and a need for more emergency and transitional housing options for people who are homeless or at risk of homelessness. Included in the plan is an updated housing vision, which you see on page 3 of the report, and 4 strategic goals. Under each of the strategic goals, the plan contains actions that we will take in order to meet those goals and realize our vision. The budget for this project was approved in last year's operating budget. It was $50,000, and you will see in finance comments that we did come in under budget, and so we had a surplus of just over $10,000. So overall, my concluding comments would be that this was a very useful planning process for us. We're very pleased with the outcome. Our consultants, SHS Consulting, were terrific to work for. Part of the program plan was that they were going to come to present. However, due to COVID, you are stuck with me as the secondary option. So my apologies for that. But with that, I'd be happy to answer any questions.
Okay, thank you, Heidi.
Questions?
Go ahead.
Yes, we had a very informative and constructive meeting with both Heidi and Marlene last night at the Housing Corporation meeting, and I would like to thank them for their input, and also Heidi has provided me with some responses to the questions that I have. And just to point out, from that study, I'm noting 0% vacancy rate in Haldimand, and I'm very anxious that we move towards addressing that. And I know in looking at our agenda for council, discussion with regard to the shareholders agreement as it applies to the Housing Corporation, and a regeneration plan is set for some time in the fall. I'm wondering if we are going to be ready for that, at least the social services. I know from what discussion that Heidi said, they are working along with the Housing Corporation to take a look at their plan. I'm glad to see that it's front up there with it. I'm glad to see that perhaps we'll have it on councils and address it in a joint meeting in September. The question I had, and it was responded to by Heidi last night. I'm looking at the implementation committee, and in some ways I see it as a hurdle. I'm wondering how that might affect all these things that perhaps the Housing Corporation has in opportunities or plans to get going, regenerate, provide more housing, more affordable housing at a reasonable rate, and upgraded, I know, in terms of some of the housing, and we spoke on it last night. Elizabeth Crescent, it was built in 1954 and it's getting rather jaded, and the other was built in 1974. Anyways, if Heidi would like to add something from it, she knows I'm anxious to get going on it. Thank you.
Yes, certainly. Thank you, Councillor Corbett. Regeneration of social housing stock means, at a high level, means that we look at the stock that we have that was built 50 years ago, and we assess it in a number of different factors. We look at the physical condition of it. We look at it in comparison to what our current housing needs are, and we see whether or not it's meeting our current needs and whether physically it's worth continuing to invest in upgrades, or like you would with your own home, as your family dynamics change and as you live in your home for a number of years and the roof goes and the windows go and the furnace goes and everything else, at what point do you say, this home is no longer serving my purposes and I need to sell it and move to something that fits my family better and is more fiscally responsible. Regeneration, as I said, is one way, but it's a very important way that we can meet the need for more affordable housing. So the plan says, and we've known for a long time, that we need more 1-bedroom and 2-bedroom units. So if we were to leverage some of the 4-bedroom, 5-bedroom townhouses, 3-bedroom single-family homes that we have, and use that money to build an apartment building that has 1- and 2-bedroom units, we are divesting ourselves of old stock that's really costly to upgrade, and we have a brand new building that better meets our needs. So the regeneration study that the Housing Corporation is undertaking and that we're actively working with the Housing Corporation on, I think runs parallel as an implementation strategy to the 10-year housing and homelessness plan. The role of our councils as the shareholders is separate from the role of the implementation committee of the housing and homelessness plan. So those two, it's my assessment that those two processes run parallel to each other, and they do connect to each other, but one will not hold up the other. The purpose of the implementation committee for the 10-year housing and homelessness plan is to make sure that we stay, that as a municipal department and as the municipal services manager, that we stay engaged with our community partners, such as the Housing Corporation and our partners in mental health and addictions, for example, because they are boots on the ground working with people who are vulnerable in need of housing, in addition to the work that we do. So we don't want to be moving a plan forward in isolation of our partners who are really important to the work that we do, because they work with our vulnerable populations every day.
I'm glad to see that coordination, and I thank you very much for entering into it. What comes out of that for us is that single-family units are no longer sustainable, and it even seems to be unattainable for those who are with marginal incomes. Thank you very much.
Any other questions on the report?
I have just a quick one there.
Okay, Ryan.
So through you, first of all, I certainly appreciate how much effort goes into a report like this. So thank you to you and your team. It was a big one to read. But just one quick question: will this be going to Norfolk Council or the Board of Health?
So thank you, Councillor Taylor. Through you, Mr. Chair, to Councillor Taylor. This report needs to be approved by Norfolk Council as the Consolidated Municipal Services Manager. However, because it is a report that we feel is particularly significant for both counties, it is our plan to present it to both councils, so that it is adopted by both councils, because we'll be working with both councils and staff in both counties and partners in both counties to move the strategic plan forward.
Thank you. Yeah, I just picked up in the recommendation there that it said council, so just clarifying that. Perfect. Thank you so much.
Any other questions on the report?
I so move.
Okay, moved by Councillor Corbett, seconder.
Seconded.
Okay, that's for the motion as Zach is printed on page 29 of the agenda. So I'll call for the vote. Councillor Rabbit?
Yes, in favor of moving.
Councillor Taylor?
Yes.
Councillor Corbett?
In favor.
Councillor Patterson?
Yes, in favor.
And I'm in favor, so the motion carried 5-0. Next report is on page 133, and it's in regards to the Ontario Works reloadable payment card.
So thank you, Mr. Chair. This report is an initiative that the Ministry of Children, Community and Social Services is moving forward with for Ontario Works, and we would like to participate in it locally. So right now in Ontario Works, we really encourage our recipients, our social assistance recipients, to get their money through direct deposit. It means that they get the money quicker, and it's also administratively more efficient for our department, because we're not printing checks, and clients don't have to come to the office to pick up checks. And in a post-COVID world, those things are going to be even more important. So the Ontario Works Reloadable Payment Card, in essence, works like a prepaid debit card, and it's for those clients who don't have a bank account and are not able to get a bank account. We don't have very many of them, but we do have some clients that for various reasons are not able to have a bank account and they still get a check. So moving forward, we would have most of our clients getting direct deposit. The few clients who used to get a check would get a reloadable payment card, and then we would no longer be printing checks for Ontario Works recipients in either our office in Dunnville or Simcoe. There's a lot of benefits to it. I think it's a really great program, so we'd like to move forward with it. The one thing that is included in the report, you will see in the appendix, is that the ministry's bank is RBC, and that is a different bank from Norfolk County as the Consolidated Municipal Services Manager. So we do need a resolution to enter into the attached agreement with the Royal Bank of Canada so that we can move forward with implementing the reloadable payment card in Haldimand and Norfolk. And with that, I'd be happy to answer any questions.
Thank you, Heidi. Any questions on the report?
I'll move it.
Moved by Councillor Corbett, seconder.
Ian, I will second.
Thanks, Councillor Rabbit. So that's the motion on page 136 of the agenda. So I'll call for the vote. Councillor Rabbit?
Yes.
Councillor Taylor?
Yes.
Councillor Corbett?
In favor.
Councillor Patterson?
Yes, in favor.
I'm in favor, so the motion's carried 5-0. We'll go on to the next report on page 145, which is the Homelessness Prevention Services Report.
So thank you, Mr. Chair. Through you to committee members, the purpose of this report is to report back to committee on the pilot program to bring homeless prevention services internally as part of the Social Services and Housing Department, and to respectfully request that Council approve making this permanent. So by way of background, for those members of committee that were not part of the initial discussions, historically, homeless prevention services were delivered through service delivery agreements with external service delivery partners. And we undertook, this was a legacy situation from prior to the CHIPPY, when there was just emergency housing. As the CHIPPY program grew to include housing with related supports, homeless prevention and supports and services, we decided to undertake a program review with a consultant who is internationally known as being a leader in developing policy and programs for homelessness prevention, and they are OrgCode. So we undertook a program review, and it was the recommendation of OrgCode that we reorient the program to be more have a more coordinated, integrated approach with the rest of the programs in the social services and housing department. We did attempt twice to issue a request for proposal. Those at the direction of the council of the day. Those requests for proposals were not successful in securing an external delivery partner. And so we did obtain approval to have a 2-year pilot project to bring the services in-house as part of the department. I certainly appreciate the timing of this report not being ideal in the middle of a pandemic, but the pilot project ends in September, and for human resources purposes, we can't have temporary positions that are longer than 2 years. So we need to make a decision on our go-forward service delivery model. On page 2 and 3 of the report, I have highlighted some of the successes that we have seen in our department as a result of homeless prevention services being delivered as part of the department internally. We have successfully implemented a coordinated access approach for homeless prevention services. So our department really has become what we would call a one-stop shop related to housing and social services and homeless prevention. We have one intake number for all inquiries related to emergency housing and housing support, which has been really great, I think, for the community. We have also shifted the emergency housing program in a couple of significant ways. One is that in the previous service delivery model, when a call would come in for emergency housing, we would try to secure motel rooms in the market at that moment. And we would sometimes be able to get a lower than market rate, but sometimes not. And we would also have to compete with other pressures in the hotel and motel industry that were going on at the time. So for example, when the Norfolk County Fair was in town in Simcoe, it was common that we would have no motel rooms available for emergency housing. When some of the industries on the border of Haltom and Norfolk bring in crews for repairs and cleaning in the summer, there would sometimes be weeks where we had no emergency housing beds because the motels were full. Our staff have secured 21 emergency housing beds with block funding at a lower than market rate in order to make sure that we have constant access to affordable rooms for our emergency housing program. We've also shifted to more of a diversion model, meaning that although we still admit people into emergency housing, we do a more thorough, robust assessment on our intake line. And if at all possible, we divert people from emergency housing in order to solve their housing crisis in the moment and get them connected to more ongoing, longer-term supports more quickly. That is a more effective and efficient way of working with clients, and it's also less costly, to be honest. There have been some growing pains in our community since we have shifted to that model. I'm not going to lie about that, because some of our partners were very used to people being placed in emergency housing immediately and not where we work with people first to try to solve the problem and use emergency housing as the last resort and not the first resort. We have had increased collaboration and integration amongst our program areas. And certainly when planning for COVID recovery in social services and housing, I'm going to be building on these successes and bringing forward a recovery plan for the department that is even more integrated. And that integrated wraparound approach is really a best practice model in working with vulnerable people. Finally, I would like to really congratulate the homelessness prevention team on the work that they have done during COVID. This team of 5 staff has developed and delivered the COVID emergency food program for both counties during COVID. And in the wake of COVID, when other partners have, and right so, started to backtrack and shut down services, our staff have still been out in the community at safe distances with proper PPE, visiting clients in emergency housing, taking people food, taking people emergency supplies, and really continuing with full service delivery, and they've just done a really great job. So I am respectfully asking that this internal service delivery model be made permanent, that the staff members be made permanent, and I assure committee that all of these expenses related to this program are within our 100% provincial CHIPI budget, and there's no municipal levy cost for this program. And with that, I'd be happy to answer any questions.
Thank you.
Comment.
Councilor Corbett.
Yeah, thank you very much. And I must compliment the delivery of the service too. There's been a great onus on addressing economic needs, and I would expect that for some people it's going to be greater. I know at implementation of this program, we had a lot of unfavorable calls, unfavorable comments, and a number of calls with respect to the delivery of service. I understand there's a transition period. Heidi, you've touched on some of the successes and how you've adopted to the transition. Are the complaints still there for the delivery of this service?
Thank you, Councillor Corbett, for that question. I think the challenges that are sometimes put forward to our team and sometimes to yourself and other members of council have been related to some of our program participants who are our hardest to serve clients. So those people who will not engage with us, and from that service delivery philosophy, you know, there have been people who and my team really wished as well that we could just pick them up from wherever that they were and put them in a safe bed and have them connect to services and, you know, be and have what we think is a great life. And yet they were not at that place, and they were not wanting to go on that journey with us at that point. And so some of the complaints that what Councillor Corbett has identified as complaints from some of our partners or members of the community that some of you have heard is in relation to that. Well, the homelessness team is not putting this person in emergency housing and they're still living in the park. Or the homelessness team has told this person that they need to explore X, Y, or Z before they'll put them in emergency housing. And that is the shift from emergency housing as the first resort to a diversion as the first resort and emergency housing as the last resort. And that's also the shift to working what we call a housing first perspective, which is that we meet people where they're at. And if somebody says to me, I'm not going to emergency housing, you can't make me, and you can't make me stay there, then I say, okay, then, you know, our staff have gone and sat on a park bench and talked to people there, or have met them in the parking lot of a Tim Hortons, because we're working with people who don't trust government, who won't come inside, who won't come in an office. And I understand that sometimes the public perception of that is that we are allowing people to remain homeless. And from our perspective, we are being respectful to those folks by saying, you're not ready yet, but here's what we can do for you. And when you're ready, you give us a call and we'll be there. And we've had some successes with some of those harder to serve members of our community who, you know, the first few tries, we didn't get there. But then when somebody showed up the fourth time, they were like, yeah, okay, I'll try it for a night and see how it goes. And they stayed 3 or 4 nights. And all of our team were like, yes, they stayed 3 or 4 nights, where the public perception might have been, well, they were gone for 3 nights and back in the park the 4th night. So that's where some of the difference in perspective has come in, and where some of what Councillor Corbett you're suggesting are the complaints are.
Thank you. And in addition to that, requires a lot of other resources: hospital workers, victim services, OPP services, and services from other organizations. So I see the frustration that goes on for all of them, and the lack of cooperation from the people we're trying to help.
Yeah, we are, the report does indicate that we have really built up positive relationships with our community partners, particularly Victim Services, who does our after hours placements, and the OPP in both counties. And there are what we call community response tables, or high risk tables in both counties, where we are active partners at those tables to try to support people so that they're not using up really expensive resources in the hospital and with the police. But you're absolutely right, Councillor Corbett, it is a challenge. I think that we have come a long way in the 1.5 years that we've had this pilot project, and I think that I'm confident that we can continue to build on that.
Thank you.
Further questions or comments on the report?
Just one question there.
Councillor Taylor?
So through you to Heidi. In the successes bullet points on page 3, with the 47% of emergency placements resulted in successful placement permanent housing. Just wondering what that figure may have been before switching the service models, and also what is the realistic target that we're trying to hit in a percentage-wise? Because 47% being in the successes, I mean, it's under half, but it's certainly in the successes. So I'd hope you'd explore that figure just a little bit further for me.
For sure. And I think that we also need to look at that figure in the context of some of the other discussion that we just had related to the stock of affordable housing that we have. So if we think about the fact that, you know, if I became homeless and I have the means to pay first and last month's rent, there's a 0% vacancy rate in Haldimand and just a few % vacancy rate in Norfolk. It would be really hard for me to be able to go out tomorrow and rent someplace to live. If I was someone who didn't have any income and had a mental illness and had addictions and had a tenant history of not being, you know, a AAA tenant, let's say, I think that creates additional challenges in our even tighter rental market. So although that 47% number is below 50, I think, you know, I'm confident, I'm comfortable with it, considering the environment that we're working in as well. Unfortunately, I don't have past statistical data from our previous service delivery model. That was not the type of statistics that we kept under that program. But working with coordinated access and diversion, we felt that that was an important statistic to keep going forward. And we, in terms of setting benchmarks, over the last 6 months, we've been working actively with our quality performance accountability and planning team, the QPAP team, with Shamir and his colleagues around setting benchmarks and targets going forward. So I would say that 47% is our starting point, and I would certainly want to see improvement in that moving forward.
All right, thank you. Yeah, those are certainly some of the assumptions I had looking at the figure, but glad to have that cleared up, and thank you. And with that, if there aren't any other questions, I'd be happy to move the report.
Thanks, Councillor Taylor. Do you have a seconder?
I would like to second, but I would like to speak to it. Ian here.
Go ahead, Councillor Rabbit.
And with that, I just wanted to really congratulate Heidi and her team and all of our staff members that have been involved with this project. I am not surprised that it's been successful and that it's led to a permanent seed. I saw the writing on the wall when we were early into the pilot of this project, and so myself as a councillor, being an early adopter, you could say, I'm not surprised that it's led to this outcome. I want to ensure that my colleagues and ultimately when it goes to Norfolk Council aren't surprised by that either. And I worry that it may draw some ire when you're looking at a temporary role to a full-time equivalent, and that's all they may see on contained in this entire report. Not just to speak disparagingly of my colleagues, but I worry that may stand out instead of all the good work that's been done to get us here, type thing. And within the report, I do want to ask for a friendly amendment if Councillor Taylor is amenable to it. With Haldimand County staff's response, if we look in interdepartmental implications, it's on page 4 of 6 of the report. It is expected that if there is a change, staff will report back with options and recommendations to address any program funding shortfalls. So this is just a comment suggesting that, right now, Heidi's team and this team has had a really good track record of staying within the envelope. And it is 100% funded, and we're all hoping and expecting that to continue, hence the ask here. But I think it would probably ensure a little bit better of a comfort level for those at Norfolk Council that may not be as well informed, to clearly lay it out that it's 100% funded now. It's been a successful program. We've got these 5 amazing people delivering this service. We want to give them permanent jobs, and we have. It's budgeted for. It's within the envelope. I just really like that clearly articulated within the recommendation here. And I think that if we were to paraphrase from Haldimand County's paragraph there at the bottom of page 148, I would find that sufficient if it just acknowledged, and you can wordsmith that if you will. I would even quote directly from that paragraph there. If Councillor Taylor's understanding where I'm coming from, why I'd like that in the recommendation, because I think it's to be celebrated and credit is owed where credit is due. And Heidi's team, like I said, has done a remarkable job of staying within that funding envelope. There is no levy impact. It's budgeted for, and these people have paid their dues. Our staff members have paid their dues through a pilot project, and they've done remarkable work in our community, and it should be rewarded with some tenure and with a full-time position and a little bit of job security that comes with it. I think that's what we need to communicate to our staff through this recommendation.
Thank you, Councillor Rabbits. If I could, Mr. Chair, could I provide a little bit of clarity and then a suggestion for an amendment?
Absolutely.
So just in terms of the clarity and the staffing positions, one of the things that I neglected to mention, and my apologies, is that under the Housing Services Act, it is mandatory that municipal services managers deliver homelessness prevention programs. So if it is decided that the internal service delivery model is not something that should continue in this community, then we will need to make sure that the programs are delivered somehow with no break in service to the community, because it's not an option not to deliver them. Particularly when it is 100% funded. So, and I do have some concerns, and this is not the reason why I'm recommending that they be made permanent. I'm recommending it because I believe it's the right service delivery model for our community. But logistically, if we were to decide to do something else, I do believe that it would be very difficult to go out to the market and complete an RFP process in time for September. So it, and there was, we wanted to give the pilot enough time to be able to show you the results while still bringing it to you in time to make decisions for us to make sure that we have no break in service to the community. So that's why we didn't bring it in January, because we felt that enough time had not gone in the pilot yet to really show you a true reflection of the work that the staff has done. So I just wanted to point that out. There are also no additional FTEs being requested. These FTEs are already part of the department complement. They're just temporary. And according to HR advice, it's actually 2 years less a day, because once a temporary position, I don't want to speak for my HR colleagues, but what I've been advised is that once a temporary position moves past the 2-year mark, it's no longer considered a temporary position. So that was done very explicitly. So thank you for letting me clarify that. And I think that we could easily add a last clause that says, and further that, it is expected that if there is a change, staff will report back with options and recommendations to address any program funding shortfalls. So that would be a direct quote out of Haldimand County's interdepartmental comments.
Hey, Heidi, I think we can add that as a friendly amendment, because it doesn't really change the context of the motion.
No.
So, mover and second, it has been moved and seconded, and I see no other, so I'll ask for the vote on the motion on the page 149, top of page 150 with the friendly amendment, starting with Councillor.
You cut out there when you called the councillor's name. Sorry.
Sorry.
Yes.
Sorry. Councillor Taylor?
Yes, and after this, may I just make a quick comment once we've got the voting out of the way here?
Sure, before I call Councillor Corbett.
In favor.
Councillor Patterson?
Yes, in favor, and I also have a quick comment when we're done, since we're not able to make eye-to-eye contact.
Okay, and I in favor. So the motion is carried 5-0. Councillor Taylor, go ahead and make your comments.
I'm just not sure if Heidi is going to be around for the next reports or not. I don't think so. So I just wanted to say that the Ingwell project is well underway at this point. It's right across the street from the office here, so I get to see it daily. And just like to say thank you for all the work that you and your team put in on that. And it's certainly making a huge difference downtown. And to the Haldimand County colleagues there, if you guys are coming through Simcoe, certainly stop and take a look. It's very impressive what they've got going on.
Great, thank you. Councillor Patterson?
Yeah, thanks. And just a bit of a positive comment, so the other councillors are aware. We had an issue earlier in the spring with some of the emergency housing in the Jarvis kind of brought to attention due to this current crisis, due to the lack of taxis willing to pick up some folks that needed rides. Anyway, it was causing quite a few issues with surrounding neighbors. I reached out to one of these 5 staff that thankfully are now permanent, and this issue was resolved to everybody's liking, and very promptly, probably within 12 hours. So I just wanted the other councillors to be aware that this is a very good team in actual operations, hands-on, and well worth having.
Okay, thank you. So we'll move on to the next section, quality planning, accountability, and performance. On page 151, we have a staff report regarding community needs assessment report.
Through the chair, I'd like to introduce Catherine Bishop-Williams, who actually led the community needs assessment, and I'm going to turn it over to her to provide the report, and then we're here to answer any questions for committee.
Thank you. Through the chair to committee members, as was just introduced, my name is Kate Bishop-Williams. I have a PhD in epidemiology, and I was the lead researcher for this community needs assessment project at the end of 2019. As it's stated, it's important to share the purpose of our project, which was to understand the community needs as part of a community needs assessment. And this was intended to set priorities for action while seeking local input. So very much an important component of our public health standards, and something that is really required of our health unit moving forward, to be able to take that input and set priorities across the unit more broadly. The research contained in the report, and that was contained in the project more broadly, included 4 key components. They were a profile of the community, a survey, and focus groups and interviews. Briefly, our community profile involved a series of data acquisition components that allowed us to seek out information that describes all of the communities across the 2 counties, and allowed us to really look at what available data existed to describe the communities across a broad number of characteristics. The second component of that was the survey, for which we had 427 responses that we were able to analyze. And the survey focused really on the perspectives and behaviors of community members, again, across the range of both counties. This was primarily conducted as an online survey, but we did have several community institution members that allowed us to provide paper surveys for collection through various sites, not limited to, but including the health unit offices across both counties and all library branches across both counties as well. The focus groups and interviews, we had 46 participants across our focus groups and 124 interview participants. And these were in-person conversations that allowed us to dig a little bit deeper into the various perspectives of our community members, particularly focusing on hearing from key informants, whether they were institutional partners or lived experiences. And both of those different types of key informants provided really deep, rich information that allowed us to have conversations about some of the things that we thought we were hearing from the survey, as well as looking for what priorities those different individuals might be wanting to bring to our attention. As far as the analysis is concerned, we analyzed each of the 4 components, but it's really important to acknowledge that in addition to isolated analysis of each of those components, we also analyzed through a method called triangulation, which involves the taking of information that came from each of those sources, and we brought that information together to look at what similarities and differences we were hearing across the different components, as well as across different segments of our population. And so that really gave us a deeper understanding of what we were hearing from the community. So just to highlight some of the key results, I'll go through several important priority areas that emerged from the data we collected. The first and likely foremost was mental health and addictions information that we were collecting. It sort of rose to the top in all of our components of research as being a really major priority for our community members. Our information that we collected in the data suggested that we were seeing very high needs for mental health and addiction supports, but that there were several difficulties in accessing some of the existing supports. Those boiled down primarily to things like the wait times for accessing services, the cost of utilizing services that were available, and transportation to access services, particularly for residents in the most rural communities of our 2 counties. A second major priority area was physical health of our residents, particularly highlighting areas of nutrition, rates of cancer, and sexual health issues. And the other major issue that fell under this umbrella term of physical health was a documented need for or existing lack of available family physicians for residents across the region. And so that was something that came up again across those multiple components of our data. The third key priority area was to talk about poverty. And this was really a key priority that intersected all of the other priority areas they being, again, members of each of our communities across the various components, talked about psychological and physical stresses of poverty, really acknowledging how poverty was a major driver for both negative mental health outcomes and physical health outcomes, and really wanted to stress how important it was to us to understand the impacts that poverty was having on health here. The fourth is access to products and services, particularly related to access to transportation, again highlighting the differences between some of our more urban areas compared to our most rural communities, access to childcare services, as well as identifying that this was sometimes a barrier to employment, which was then a driver of poverty, access to food, and highlighting some areas that were identified as food deserts in some communities where there wasn't access to things like a local grocery store. And lastly, access to youth programming. And so this became a major topic that became the most highly discussed topic around youth health or services, being that it was a major driver for loneliness and boredom, as well as often considered a driver for experimentation with drugs, vaping, and alcohol. And one of the major reasons that we heard from our institutional key informants that drove some of the problems with access to products and services was the vast geography of our counties. And there's no question that everyone, all of our councillors will understand that the vast geography of our region really does complicate service provisions, but it's something that came up again and again that's worth investigating and talking about further. Lastly, the last major component of the data structures was organizational structures, and what the implications of our organizational structure here at Health and Social Services might be for interaction with the community. The key areas under organizational structures that came up were, number one, collaboration, so encouraging Health and Social Services really in two ways. Number one, first, build even stronger and more plentiful connections with community partners. And there was absolutely a recognition that these partnerships exist and that they're great and that they're growing, but just an acknowledgement there that it was something that people would like to see even further developed. And secondly, under collaboration, being that liaison to try and connect existing community organizations to try and provide opportunities for them to collaborate directly as well. Secondly, under organizational structures was communication, and this referred partially to collaboration, which I've just discussed, as well as highlighting communication needs in a way that they were looking for that much more communication from the Health and Social Services out to the general public, acknowledging that we do provide press releases and pamphlets and all sorts of different information. The reminder that came up in these conversations was really just that we need to be investigating the most appropriate, most timely, and most accessible versions of communication, highlighting that social media was a really accessible way, particularly to reach our youth in our communities. Third, under organizational structures, was to meet people where they're at, acknowledging that this was something that they're seeing an increased awareness of. For example, if we lean back to what Heidi was just discussing and how the homelessness prevention services are really actively working on meeting people where they're at. So again, this was a lot of acknowledgement of successes and encouragement to continue pushing forward under that lens as well. Lastly was operational changes and anti-oppressive actions. And so this was a reminder again that Health and Social Services is working hard to be a welcoming and accepting building and community partner, and just an acknowledgement that there was still space to work forward in this. And one thing that was important to acknowledge under this anti-oppressive actions heading was that the community partners who we were talking to, as well as some of our key informants with lived experiences, really felt that there was an opportunity for Health and Social Services to be the community leader in driving even further action under anti-oppressive actions, and really trying to be an example of what best case examples could look like and how we could provide some of that training into our community members as well. So our next steps under what we've reported at this time were that this was really intentionally designed and implemented as a way to apply the results to future planning phases, particularly as part of our strategic planning phase that comes up later in this year. So with that, through the chair, I'd like to request that this information is received as information, as well as request endorsement for the use of these findings through the next strategic plan. I'm happy to take any questions at this time.
Thank you, Catherine. Any questions from committee? Seeing none, I'll ask for a mover and seconder for page 155 of the agenda.
So moved.
Councillor Patterson, seconder. Councillor Taylor, pardon me, seconder.
Councillor Rabbits?
Councillor Rabbit. Okay, so I will call for the vote, starting with Councillor Corbett.
In favor?
Councillor Patterson.
Yes, in favor.
Councillor Rabbit.
Yes, in favor.
Councillor Taylor.
Yes.
I'm in favor, so that motion is carried 5-0.
Thank you for your time.
And Allison, you can sit here, I'll just clean it. Okay, what kind of PowerPoint right away? Want your PowerPoint over there? Yes, please.
Okay, everyone, I'm going to attempt to share my screen here. Bear with me. I have a PowerPoint presentation. Let's see if I can get this working here.
Good. You have to air dry yours, but don't blow on it.
Oh, please don't lose me. Can you guys see it? No?
There we go.
Yeah, I don't know if they can see
Yeah.
it. You can see that?
No, not yet.
Oh, that's what I thought. Let me see here. Because it's not coming up at the bottom. Come on.
Hello, is everyone there?
Yes.
Not sure what happened there. Did you lose your connection, Bernie?
I believe I did.
Okay, I did too. I'm back now.
Yeah, the room isn't back though, as far as I can see.
Yeah. Okay, well, we'll just hang on for a second. Maybe it's trying to get everybody else back.
Did I lose everyone?
Yeah.
There we are.
I don't know how to get this up here. Let me
Maybe that's
just-
the share.
Yeah,
It's trying to load.
but I don't have it here. I'm gonna not share it first. I'm gonna open
Marlene,
it.
Marlene, can you hear me?
I can hear you, Councillor Del Monte.
Okay, everything
PowerPoint.
okay, everything went black. We're coming back now?
Yeah, can you see the PowerPoint presentation?
No.
No.
Why it's
We're
not-
trying to share it and just so, just give us another minute or two, so
Okay.
Share.
technology.
You see, it's not coming up down here. I don't know why it's not.
If it's not very well, you can just read off your audio playback up.
Okay, I don't think it's gonna work, guys. Sorry.
So Allison and Margot are here to present the report, two of our public health nurses who've been working on the social determinants of health. What we'll do, I'll ask Kristen to circulate the presentation after so that committee members can have it. And for those three Norfolk committee members, you'll see it at the next Board of Health meeting in early July. So if I could ask you to present, that would be great. Thank you.
I'm Margot Fournier, and this is my colleague Allison Dunn, and we're here today to provide you with information on the social determinants of health. Income and income distribution. Income is probably the most important social determinant of health. It not only influences health behaviors and psychological functioning, but it also determines an individual's overall living conditions and impacts on the quality of their other social determinants of health, such as housing and food security. Research has determined that in any given society, those with higher incomes do better on a range of health outcomes. There is therefore a social gradient in health, meaning that every step up the socioeconomic ladder leads to an increase in health. In 2019, the Hamilton Spectator, in collaboration with McMaster University, published a 10-year update on their Code Red series. Researchers found that less affluent neighborhoods were 5 times likely to not have a family doctor, had 2 times higher rates of ER visits, had 4 times higher rates of urgent hospital administration, 9 times higher rate of ER psychiatric visits. Income inequality, or the degree to which total income is distributed unevenly throughout a population, also impacts on the health status of individuals and populations. Income inequality has been linked to differences in health outcomes such as life expectancy, infant mortality, hospitalization, and mental health. Research has shown that countries with greater income inequality have worse health outcomes. The low income measure at 2015 showed that Haldimand Norfolk overall poverty rate is 11.74. However, we have to remember that is only an average. There are some towns and the poverty rate is as low as 5%. There are others with poverty rates as high as 16.8%, 17%, and 21%. It is important to keep in mind the linkage between income inequality, and poverty, and the effect that they have on health outcomes and the cost to society as a whole.
Employment and working conditions are other social determinants of health. And in general, a good paying job makes it easier for workers to live in healthier neighborhoods, buy more nutritious food, and provide good quality education for their children. Good jobs also tend to have good benefits, and all of these impact on health outcomes. Research has found that higher earnings translates to a longer lifespan in general. Unfortunately, according to Feed Ontario's 2019 Hunger Report, food banks are seeing an increased usage of their services by individuals who are employed. Although social assistance users are still the largest group of individuals who access food bank services, there has been a 27% increase in the proportion of people who are employed yet still accessing food banks. Low income and insufficient work hours were the primary reasons given for accessing food banks by individuals who are employed. This report also examined our changing labor markets, and what they found was whereas in 1988, the majority of people employed in minimum wage jobs were youth in high school, now nearly half of all these minimum wage earners are 25 years of age or older. And of these workers, nearly 1/3 have a post-secondary degree, and almost half of them are working full-time. In 2019, the United Way of Haldimand and Norfolk calculated that the living wage for our counties was $16.58 an hour. It is considered to be the hourly wage a worker needs to earn to cover their family's basic everyday expenses, such as food, housing, shelter, childcare, and transportation. Current Ontario minimum wage is $14 an hour, which falls short in comparison. Working in a job that has poor working conditions also has detrimental effects on health outcomes. People who are already most vulnerable to poor health outcomes due to lower income and education tend to be the ones most likely employed in these adverse working conditions. About 30% of Canadian workers feel that their employment puts their health and their safety at risk.
Employment provides income, a sense of identity, and it also helps to structure day-to-day life. Unemployment frequently leads to material deprivation, social deprivation, psychological stress, and the adoption of health-threatening coping behaviors. Lack of employment is also associated with both physical and mental health problems, such as sleep deprivation, high blood pressure, heart disease, depression, anxiety, and increased suicide rates. Unemployed people face numerous health challenges beyond loss of income. They are far more likely to have fair or poor health and to develop a stress-related condition, such as a stroke, a heart attack, heart disease, or arthritis. Along with the number of people working in minimum wage jobs, we are also seeing a rise in precarious employment. Working in involuntary part-time employment, working on contract or in temporary or seasonal work, and being self-employed are all forms of precarious work. In 2014, Stats Canada labor market study determined that 1/3 of all Canadians working were in unstable employment. RNAO reported that the lack of decent work and living wage is taking a significant toll on the health of workers and their families. People who are precariously employed are at double the risk of diabetes, 2.5 times more likely to experience fatal occupational injuries, and have a 40% higher risk for heart disease. And in comparison to those in secure employment, are also 55% more likely to report that they are often depressed as a result of work.
In Canada, we are lucky enough to have programs and services that support individuals and families going through changes in their lives. These are collectively known as our social safety net, and they include such things as social assistance payments, unemployment insurance, pensions, and health insurance. Ongoing challenges have been identified with these programs and services. For example, social assistance rates have not been increased with inflation, so are insufficient to cover essential costs such as purchasing nutritious food, safe and adequate housing, and utility costs. For employed individuals, there have been changes to the WSIB and EI systems, and these have been weakened. 46% of injured workers with permanent impairments end up living in poverty 5 years after their accidents. As well, with the rise in precarious employment, only 40% of working Canadians are eligible to receive EI benefits, even though they've been paying into it. These gaps in the social safety net can lead to a lack of income, which in turn leads to poverty and overall poorer health outcomes. The final social determinant of health we would like to discuss today is that of food insecurity. Household food insecurity means that a household has inadequate or insecure access to food of adequate quality due to insufficient income. It is a major public health concern because it's associated with inadequate nutrient intakes, poor mental health, increased risk of chronic diseases such as heart disease, hypertension, and diabetes. Year after year, our nutritious food basket reports have demonstrated that a nutritious diet is unaffordable for our vulnerable populations who live on low income. Of households whose major source of income was social assistance, 61% were food insecure. However, it is not just those living on social assistance who are vulnerable to food insecurity. 62% of food insecure households also rely on wages or salaries from employment. According to the CCHS, Canadian Community Health Survey's food security model, 1 in 9 families in Haldimand and Norfolk are considered to be food insecure.
And in closing, we are hoping that the Board of Health has a better understanding of the social determinants of health and their impact on health equity, and that it will enable the Board of Health to advocate for and support the development of healthy public policies that facilitate health through the reduction of health inequities. One of the strategic priorities, we are hoping that the Board of Health, with this information on how income has, as a social determinant of health, impacts the vibrancy and creativeness of the community. In acknowledging and educating our community on the effects of income and other related social determinants of health on health outcomes, it provides us the opportunity to begin the important work of advocating for public policies to support those most negatively impacted by these determinants. We would like to thank you for your time, and we will now take questions.
Okay, thanks very much. Are there any questions to staff on the report?
I have a question. Councillor Abbott's here.
Go ahead, Ian.
Thank you. And through you, I'm going to direct my question to our public health nurses, and thank you for your service and for your report. I wanted to dig down a little bit on food insecurity, and I just wanted to maybe start with a comment and see if you would correct me or provide some more information. With regards to food insecurity, a concept that's been introduced to me is the idea of a food desert. And to my understanding, a food desert is a way of describing a part of our community that is isolated from the grocery store, that is isolated maybe from a convenience store. They tend to be lower income areas. With the urban sprawl, these areas tend to be away from maybe a downtown core or just adjacent to. Often the individuals residing in these food deserts, as I'm attempting to describe them, they have disabilities and they have inaccessibility to public transport or their own vehicle. And maybe just to give you a little anecdote to highlight the concern that I have is I'm a bachelor, I'm a single fella. I go to the grocery store, it takes me 15, 20 minutes on a good day. I'm in and out, and I take that for granted. There's members of our community that for them, due to their disabilities, they're immobile, they're not ambulatory, maybe they're using a medical prosthesis to walk or a medical device, or confined to a wheelchair. In addition to not having access to other things I take for granted, like public transport or my own vehicle, a 20-minute trip to the grocery store for me is an 8-hour workday for them. Those that are living in these food deserts, as I'm attempting to describe them. And that's on a good day. So now we're living in the COVID-19 era where when they finally get there to the grocery store, now there's queues to get in. It's much more difficult for them to negotiate not only getting into the store, but getting back with the additional precautions and all the closures of different services. And, I'm concerned now that, once, a full-time job for a person living this way, now they're working overtime in a way, just to get the necessities of life and to get the proper nutrition. So again, it's not necessarily someone that they may have a job, they may have a source of income, but it's due to their disabilities and their inaccessibility to the food source itself. I worry it's becoming unmanageable for that person. That really they're working overtime just to get the necessities of life. By the time they get home, they got to wake up, they got to do it all over again. Maybe they're able to plan out their week. And I'm just wondering for those main areas where maybe they're highest traffic for, I'm thinking of food basics, I'm thinking the independent grocers, those that service that population more. We have times for our seniors to get in early and things of that nature. I just worry that this problem of food scarcity or an inability to get to the food and get it to home, wherever home is becoming exacerbated by the COVID-19 crisis. And I'm wondering if our public health nurses have any commentary or any suggestions about that. I'd love to see the food insecurity portion of a report such as this, or even in the future, have a couple pages dedicated to the scenario, the description as I'm attempting to describe it.
Do you want to answer, Marco? Or okay, through the chair to Councillor Rabbits, I would concur with what you're saying. I know Margot and I both have clients with disabilities. I remember one of the ladies talking to me about being happy to take public transit to a place that had food that was more affordable. However, physically getting off the bus and then making the 15-minute trek home, she couldn't carry all those packages. Now I'm thinking she was already vulnerable enough before COVID-19. So then we add, like you say, a woman who couldn't make the physical trek from the bus stop to home. We add to her standing, like you say, for hours in a line, or even if it's only minutes in a line. And then you add on the anxiety of being out in a population when you're more vulnerable because of your health issues. I have another lady who has access to transportation, but because of her weakened immune system, can't get out. So she's not willing to put herself at risk standing in these lines. So what's been happening is, fortunately, we've had community services Health and Social Services, Church Out Serving in Simcoe, I think most of you are aware of them, who have been trying to reach out to this population. But again, there are always those that we miss out there. So I would definitely concur that this has exacerbated the issue. What I would like to do is, if we are able to present that type of report, is actually bring our dietitians in, because they have a really good understanding of the food deserts in our area. They understand about food insecurity, and I know that the dietitians of Ontario, as well as our dietitians, have been working together to try and put together some public policies to address these type of issues pre-COVID. It would be interesting to see what they would have on their plate now post-COVID and then going forward.
Excellent. Thank you for that response. You know, I'm not looking to necessarily, advise for a staff report or to direct staff with those comments. I just wanted to, for my colleagues' benefits, to put that on the table and, express my interest in having some more information on that topic come to the advisory level and eventually be presented to council, because I think it's a really important topic. And for myself, trying to wrap my head around the issue, I'm wanting to know where those geographic areas and where those populations are so I can better serve them through advocacy. And I also want to, be sensitive to the fact that maybe we don't necessarily want to, that is sensitive information. So I'll leave that in your capable hands at how that should be presented. But I just wanted to express a keen interest in the topic, and absolutely partnering with our dietitians and having them join us in serving this community is a wonderful idea. So thank you so much for your response.
Thank you. Ian, are there any other questions or comments on this report? None? Then okay. Margot and Allison, it's good to see the two of you again, and keep up the outstanding work. Hope to see you very soon.
Thank you, Councilor Delamonte.
I'll ask for a mover and a seconder for the motion on page 188.
I'll second it.
Thank you.
I'll move if that hadn't been done yet there.
Okay, Councilor Taylor, Councilor Corbett. I'll call for the vote, starting with Councilor Rabbit.
In favor, yes.
Councilor Taylor,
Yes.
Councilor Corbett,
Favor.
Councilor Patterson.
Yes, in favor.
I'm in favor, so that motion is carried 5-0. So moving on, there's nothing listed under the subcommittee report.
We'll capture this.
Are there any questions or comments in regards to the two items listed as communications? Otherwise, we'll just have a motion to receive.
I'd just like to make a comment, if you will, Mr. Chairman.
Mm-hmm.
With regard to the affordable housing development, Aspen Apartments in Dunnville, I would like to thank Heidi and the group in allowing me to see an idea come to fruition. Thank you very much.
I'll echo that as well, Councilor Corbett. Any other comments on those two items? I can have a mover to receive the two items of communication as information.
I'll move. I'll move
Yeah.
for information, Patterson.
Okay, Councilor Patterson and Councilor Rabbits,
Sounds good to me.
seconder? Okay, sounds good to me too. So calling the vote, starting with Councilor Corbett.
In favor.
Councilor Patterson,
Yes, in favor.
Councilor Rabbits,
Yes, in favor.
Councilor Taylor.
Yes.
I'm in favor, so that motion is carried 5-0. Under other business.
I do have a comment I wish to make.
Okay, under other business, okay, go ahead, Councilor Corbett.
Yes, I wish to put my feelings on record with regard to the COVID-19 response. I sat on the transition board to guide the restructuring of Haldeman Norfolk creating two separate municipalities, Haldeman and Norfolk counties. The province decided, not the transition board, that Norfolk County would bear the responsibility as a consolidated service manager. Patty Moore, at the time, the manager, proposed, and it was accepted, a solution which afforded opportunity for input by Haldeman County. In my estimation, it has been a very effective way for Haldeman County to put forward its concerns and responses. Haldeman County appoints 3 members to sit on the advisory committee. Our mayor is not a member of this committee. As a member of the advisory committee, I feel our comments during the COVID-19 response have been muted. Decisions have been made without input from our members. Our residents look to us for comments. How can we respond? We are not consulted. We are not given the results of the decisions made. I am sure this inequity will be leading to future discussions with Haldeman, and maybe we will see a restructured health board or health unit board to address these concerns. To me, these meetings are essential. Thank you.
Thanks, Councilor. Marlene, did you want to comment?
Through the chair, thank you for your comment. It has been challenging with communications, and we were advised not to defend it, but we were advised not to have advisory committees of any sort until June. We did attempt to have one in May. That doesn't negate the need to communicate. We have had, as Councilor Corbett's indicated, both mayors at all of our EOC meetings, respecting that he is not part of this committee, and staff have been involved. So I will own some of that. I apologize for not having more communications. I know that Dr. Nessathuri does provide reports to the Board of Health, and he does include the advisory committee members. As always, Dr. Nessathuri and I and our teams are here to answer any questions. Several of you have reached out over the last 3 months. At any point in time, if you have a question, if you want some follow-up, we're happy to do that. And moving forward, we are going to keep our advisory committee meetings now that we have a platform to do it. And if you would like to have an additional meeting for more information, we can definitely do that. And I am here today, and I'm happy to answer or try to answer any of your COVID-related questions to assist with the communication.
Thank you very much. I did take the opportunity to sit in virtually on one of your meetings, the last meetings that you had with the health unit. Unfortunately, it took about 5 hours, and for me, it ended up being at 2 o'clock in the morning. When you take your breaks, I couldn't take my break. I was still waiting for you. I can only say that we need to have some information from for our public, as we are responsible. And if I may, I appreciate, the doctor has responded to many of my calls, and I know you're quite busy. I don't want to hold another meeting. If we can keep the information going, I'd be quite pleased with it. And I believe from what you said, you're going to address it. So thank you.
So committee is where Dr. Nessathuri is currently writing a report for the Board of Health, and we'll ensure that advisory committee receive that report as well. Not just that through the Board of Health tomorrow, but I'll ask Kristen to circulate it to everyone as well.
Okay, thanks, Marlene. Thanks, Marlene. So, Marlene, safe to assume at this point that we will be having a meeting, advisory meeting on June 18th?
I'm sorry, Councillor Del Monte, can you repeat that? You just cut out there halfway through.
Okay, is it safe to assume that we will not be having an advisory committee meeting on July 16th?
We haven't made that determination. We did have a meeting with the Housing Corporation yesterday, and we were talking about the regeneration project and the shareholder agreement. So we haven't committed yet, but we were thinking, Heidi and I, that maybe that date would be an appropriate day, as some of you are already technically available, but we'll confirm that. Related to an actual advisory committee, we haven't made that final determination, and I'll respectfully turn it over to the committee. If you would like to continue, we can definitely have a meeting specific to more COVID-related commentary, limited probably reports, definitely moving forward for an August one. So I'll open it up to committee. We typically don't have one in July just because of the summer break. But more than willing, given that we're trying to do catch up now, because as you can appreciate, it's a new world we're living in right now.
No, I do, actually, Marty, where I was going with this is that whether we meet in July or whether we meet in, I'm quite willing to meet either time, but my request is that we have an in-person meeting at your building in Simcoe and not at anymore. We're meeting in Haldimand Council next week, or the 30th, and we're also having the week next week. I would assume that it's safe to have our advisory back face to face in Simcoe.
So through the chair, I know that feedback did come to Kristen earlier, and unfortunately, because it came just kind of in the last 24 hours, we didn't have time to mobilize that. I agree, a face-to-face is always better than this, and we have had council meetings with success, a little bit of technology glitches, but still successful with a few of our council and board members partaking virtually, and that can be available to you. I would recommend one of two things, and we can discuss it with clerks, that we have it in council chambers here in Simcoe and with appropriate social distancing as we're currently doing, or we consider the emergency operating center here at the GAD facility, because we could actually have the committee members separated to adhere to the social distancing and have additional people if they so chose to partake on virtually. So Kristen and I will work to accommodate that for our next meeting whenever that should happen.
Okay, thank you. Is there anything else under other business?
Ian here.
Go ahead.
I just wanted to thank you. Through you, I just wanted to affirm that I would like to meet in July. I am pleased that we can arrange to meet in person. I do know that we have that training space at Gilbertson that's a little larger of a room. Is that what's being currently utilized as the EOC? That larger room in the back there? Yes.
So, Chair, Councillor Rabbits, yes, that's our emergency response control room for the county, and that's where we meet for emergency response, and that's currently what's being utilized. But we can make sure that the space is available for that afternoon. Unless things change drastically where we need to be there, I'm sure we can make those arrangements.
That's great. I think we should plan to have everyone in attendance, and if we have a smaller party, then that is just more physical distance between us. I did want to reiterate that I was looking forward to a Haldimand Norfolk Housing Corporation presentation, if not an informal update or a memo. I know that we had a really fruitful discussion last evening at the board level, and we just wanted to, from my perspective and for my colleagues, we wanted to start a conversation about asset management with our community housing portfolios. We want to start an early conversation about the sale of singles and semis to put more roofs over individuals' houses, and to look at some non-monetary options. The county has some lands, and to how we can move forward with regeneration in both Haldimand and Norfolk counties. And I wanted to start this conversation myself early on and at the advisory level, knowing that we'll be meeting in the fall. It'll give us a chance to sort of digest that information over our summer recess. And if we could just meet in July, we're going to have a break And everyone knows that once you come back to the fall, that's when it's back to business, right? That's when reality sets in, your summer vacation's over, and it's time to get to work. So I was hoping that we could lay this early groundwork so that when we have our shareholders meeting, the advisory committee members, they're going to be informed of some of these objectives, and you'll sort of get that, oh yes, I remember talking about this, or yes, I was involved at an earlier stage. And I think that we'll get some good buy-in that way. And ultimately, it'll lead to having a more successful project once we get to shovel ready. So, there's some early work on preparing whatever that presentation, that material will look like. If we get some other business caught up on or accomplished then, that's all the better. So I'm really looking forward to meeting in July, having a breath, and then getting back to business in the fall. So, those are just my comments, and I'm very pleased and I feel confident that we can meet safely and in person. So thank you for that opportunity to speak.
And July will work fine for me as well.
Okay. So Marlene, there's nothing listed under the closed session. Unless you have anything else, then I would suggest we can adjourn.
If I may, Councillor Del Monte and committee, so for July, a little bit out of regular process, but this is not regular, and we're still trying to start some business continuity here. But for July, clearly, the Housing Corporation regeneration and shareholders is a key priority. A COVID update is another key priority. From the committee members, is there any additional topic that you would like staff to prepare for July that is a priority for any of you? We would be happy to work on that and present that. If not, we'll proceed with our regular schedule and target more reports for August.
Okay. Anything else from members of committee?
I don't think so. If anything comes up, can we just email you, or if we just want a memo brought to us, just fire an email off?
That would be fine, Councillor Taylor. Thank you, and thank you for the opportunity.
Do we need a motion to adjourn, Marlene? I think we normally do, but I think before we've just closed the meeting.
You're the chair. We'll take your lead.
Well,
I'll move.
Okay, I think I've got a mover in Councillor Corbett, second by Councillor Taylor, that this meeting now be adjourned. And is there any opposed to that motion? I don't hear any. So the motion is carried unanimously. Enjoy the rest of your afternoon, folks.
Have a good day, everyone.
Thank you as well, Chair Del Monte and everyone. Thank you for hosting an effective meeting here. Really appreciate it.
Thank you. Take care, folks.
Thank you. Gotta go to EOC now. I'll call them in, Kristen.
No problem.
Thank you for that.
Bernie Corbett
is now exiting.